My name is Marissa Ferguson, and I'm going to be presenting on the maintenance of eating disorders. You're going to have to forgive me because I use PowerPoint online, and so I wasn't able to record my narration within the presentation. And so I'm recording my PowerPoint with my narration on my iPhone for you, but it'll be great. An overview. Eating disorders, according to the Diagnostic and Statistical Manual 5, include anorexia nervosa, bulimia nervosa, binge eating disorder, pica, rumination disorder, and avoidant or restrictive food intake disorder. The American Psychiatric Association 2013 states that eating disorders are a significant issue in mental health as they significantly impair one's physical health as well as their psychological functioning. I'm going to share some statistics with you, but please keep in mind that they're likely an underrepresentation as eating disorders often go undiagnosed. Mousavi and Amini, 2017, hypothesized that this is most likely because healthcare providers are not appropriately trained to identify eating disorders, and often there are not clear physical indicators of eating disorders, such as in patients with bulimia. Sungut Borden and Klungling Torsvik in 2003 hypothesized that many individuals with eating disorders don't report their illness, and that might be due to a stigma surrounding mental health issues and eating disorders. They might feel ashamed and guilty and therefore fail to report that they need treatment. So the statistics that I've got here show that up to 46% of adolescent females and up to 26% of adolescent males experience body dissatisfaction. They're dissatisfied with their body size and type. Anywhere from 0.5 to 1% of females are diagnosed with anorexia nervosa, and the recovery rate is not impressive. It's anywhere from 35 to 85%, but only for up to 79 months. And it's considered to be one of the third most chronic conditions that affect teenage girls in our country. And the last statistic I have for you is that 1% to 1.5% of females are diagnosed with bulimia nervosa. So it seems that there's a common theme in the psychology of eating disorders, which is that people feel pressure. They feel pressured to attain a certain body type. This pressure can come from one's peer or family environments, causes what Paxton 2006 calls, as I mentioned before, body dissatisfaction. We might say as behavior analysts that looking a certain way is reinforced in our culture, and deviating from this look is punished. According to Paxton 2006, in the modernized world in which slimness is valued, it's been proposed that large body size, representing departure from the current beauty norm, increases vulnerability to body dissatisfaction. So a psychologist might say that when one feels pressure to attain a slim body type based on external influences, whether it be the home or pictures that they see or videos of people online, it can lead to unhealthy eating behavior. For example, starvation, drug use, supplement use, or vomiting after consuming food. Paxton's belief is that body dissatisfaction, being unhappy with the way one looks, causes eating disorders. So that is a very mentalistic consideration for the cause of a behavior, is the way that one feels. Eating disorders and mental health. According to authors Mousavi and Amini 2017, what they call disordered eating behavior can be caused and maintained by anxiety and depression, as well as anger. Paxton 2006 attributes eating disorders to factors such as the belief that one must be thin, which causes depression and low self-esteem, when one feels that they are not thin enough as per the standards of our society, and that these states, the depression, the low self-esteem, can cause a person to engage in disordered eating. And as we looked at it before, this may be in order to produce a certain body type or to manipulate one's body type. But the important thing that we're looking at here is the why, and Mousavi and Amini and Paxton are all saying that the why is because they're sad, because they're depressed, because they're angry, and so they attempt to manipulate their diet and their eating behavior in order to manipulate their body and cause a change in affect, I guess we would say, to make them happy. So as behavior analysts, we don't say that private events like depression or feelings of being pressured cause behavior. We focus on motivating operations and the events which precede and follow behavior in order to hypothesize cause. Skinner considers anxiety to be an emotional state which accompanies responding under particular stimulus conditions. And in this way, the response which accompanies an emotional state can be addressed through a behavior analytic approach. The stimuli which occasion and follow what we would call, or what we've heard of as anxiety accompanied behavior, can then be manipulated in order to cause a change in that behavior. Excuse me. Skinner also mentions in Science and Human Behavior that the causal connection between the practice and the mode of behavior may be left to a functional analysis of relevant variables under the conditions characteristic of an experimental science. So that's when we're looking at what we can observe and what we can measure in order to determine correlations between what's going on in a person's life and their eating behavior, what's maintaining it. Rather than saying they're sad, we can look at the physical properties of their environment and their interactions with other people. And maybe just their interactions with their environment, what they see and what they're exposed to. So also in behavior analysis, we also have to remember that it's considered best practice not to rely on questionnaires, interviews, or self-reports alone. Although we do use them, we don't limit ourselves to those modes of research when we're determining the cause of behavior. When possible, we conduct direct observations of the organism or the individual being in their natural environment or in a controlled setting. This is a consideration we can absolutely make when addressing eating disorders as well. It may be problematic as the individual being observed may behave differently than he or she would in private, and that's a significant, though not uncommon, limitation to consider. And we also have to consider the possible danger that this behavior would present to the individual, such as when we study other self-injurious behaviors. For me personally, with my clients with autism who engage in certain self-injury, you can only observe to a certain extent before it becomes dangerous to them and you have to intervene. My proposal, I would be interested in conducting a single subject research study using treatment-based results of a functional behavior assessment, which would include interviews as well as direct observations and possibly a functional analysis.